Good afternoon, viewers. It's truly a joy and pleasure to be once again be with you all. And today we are having a panel discussion on a very special topic. Being an Indian doctor, this is a very exciting time for anybody to be in India and be a doctor at the same time. There are issues also attached to it, and that's what we are going to discuss. And we have a very eminent panel to take this issue forward. We'll discuss threadbare the drivers of healthcare medicine related issues, wings of medical infrastructure, expanding the healthcare horizons. And to my right, and to my right, all the three panelists that I'm introducing are very specially devoted to this concept, and they have been working on the issues related to healthcare for a long time. Dr. Ashok Gupta doesn't need an introduction, but it's customary to introduce him. He was recently awarded with Peace Prize, which is equivalent of a Nobel Prize in medicine, and we are truly proud. It's a Nobel Peace Prize in Asia. I've known him for a long time. Extraordinary plastic surgeon with reconstructive skills that can outdo the best in the world. He's a surgeon with a benevolent vision, set up the Reconstructive Surgery Foundation in India, an organization that caters to the reconstructive surgery, especially for the economically challenged. Dr. Gupta has also proposed to offer voluntary service to the needy at designated medical institutions with the help of experienced surgeons in the field and to extend support and benefits to the acid burn victims. Thank you very much, Dr. Gupta. It's
My
truly
pleasure.
an honor to have
My,
you here.
my pleasure to be
Dr.
here.
A.G. Unnikrishnan, who is a endocrine surgeon, but he's got an endocrine specialist. I'm sorry if I said surgeon, I didn't offend you. He's the CEO of Chelaram Diabetes Institute, a not-for-profit diabetes institute in Pune. He heads Clinical Endocrinology Research Foundation and Education Unit, and also oversees a philanthropic rural diabetes care program at the institute. A very warm welcome to you, Dr. Unik. And of course, Mr. Fanish Chandra, who makes it all happen. And we're truly here because of him. He's the co-founder and CEO of Docplexus. I must congratulate him for doing so well over the years. It's truly been a joy to be part of his endeavor to take the classrooms to the world. And this is what we need to be doing in the future. He's a pioneer in developing the digital platform for engaging healthcare professionals and an expert in providing digital solutions for pharmaceutical industry. He is the CEO and founder of Docplexus, the largest platform for Indian doctors, with a mission to empower doctors by providing them access to peer advice, expert opinion, medical guidelines, and latest advances in medicine.
Thank you.
I'm sure you have a view and a vision for the future, and I'm sure we'll be hearing a lot about that. Now, yours truly is going to be conducting this program. I happen to be a surgeon with a keen interest in cancer surgery. That's the field I specialize in. I happen to be the president of the Asian Society of Histology. I am the past president of Association of Breast Surgeons of India, governing council member of Association of Surgeons of India. I happen to be a fellow of all the four Royal Colleges of the UK and American College of Surgeons. I happen to be their examiner, and I'll be also sharing my ignorance with you in the field. What we are looking at is a wonderful and a very exciting panel discussion. And without wasting a lot of time on the usual formalities, we'll jump onto the issues. And I'll be very happy to take questions at the end. At any point that you have a question, you can always post it. Now, we will start with the first segment of the discussion, drivers of healthcare, bridging the knowledge health gap. That is our theme. And we have divided for convenience the whole thing into three parts. Medicine, a profession of noble minds. To be a doctor is considered something extraordinary, special. Is it the same today or not? I'll probably start by asking Dr. Gupta, who's I did not mention there, who's been a very active member of the Board of Medical Council of India. So he's been in and out. He's seen both sides, and he's actually the person who would be the best person to talk about the status of medical education today in India. Dr. Gupta.
Yes. Thank you, Doctor. It's my pleasure to be here. And I feel it's very important question that how we are looking at the medical education and healthcare in India. I think these two aspects cannot be delinked. A good doctor produced by the medical education system in the country is able to deliver a good healthcare. A bad doctor being produced by some of the uh, not so good medical institution cannot deliver a good healthcare to the people. We at a medical council, many a times we have discussed the issue that we have some of the very outstanding institutions which can be compared to Stanford and Boston.
Correct.
But at the same time, we are lacking some very basic healthcare provisions in our rural area. Even in the city like Bombay and Pune, there are several people who do not have access to these basic health issues. And there lies the difference in our, somewhere or other we are lacking, either the health and medical education are not collaborating with each other, or the medical education is being looked at one lucrative aspect and health is being looked at one of the expenditure by the state, so they are not able to
No, yes,
match.
that is not matching.
Not matching.
Tony, would you throw some light on that?
Yes, of course, it's a great pleasure to be here and discuss this topic. I have a view that we've come a long way if you look at the last 100 years of medicine. So maybe it is true that the pace at which healthcare delivery has progressed has not matched up to the general expectation.
Correct.
But given that, if you look at the progress in science, if you look at the progress in access to healthcare, if you look at the progress of affordability of medication, I think we have a lot of uh, reasons to be positive about. But at the same time, we can do better. I think one of the important ways to look at the problem is to keep the patient in mind and find out ways and means in which we can get the best quality, affordable, and excellent healthcare to them. So affordability is also key. Excellence is also key. You have something excellent, it isn't affordable, no point. If you have something affordable, but it isn't up to the mark.
No, yes.
So
You actually
affordable
you
excellence.
hit the
Yeah.
nail on the head. We need Indian solutions to Indian problems.
Yes.
We don't need Western solutions to Indian
Yeah, I want to add one point on
Yes.
this. I'm being part of the JJ Hospital, which is the third oldest institution of the country. It was started in 1845. Also, having graduated from Medical College Nagpur, which was the largest campus in Asia. But both these institutions, we have loads of patients coming, more than 1,000, 9,000 patients coming. But we have yet to reach to that level of excellence. I mean, why these institutions?
Yeah, the volume is our strength,
Yes.
but it's also our weakness.
Absolutely.
Because when you have too many to look after, the quality may suffer.
Absolutely.
Yeah.
Your views on this, Mr. Fanish, just to give your inputs on the distance learning, because that part is a very important aspect of what I was thinking. I mean, expanding the classroom, having distant learning in the form of CMEs, webinars. What has been your experience? Because you're on the other side of the table.
Yeah, from the technology perspective, the solution that we are bringing kind of tries to bridge the gap between different knowledge silos we have. At one hand, we have centers of excellence, eminent faculties, and on the other hand, we have poor access to those faculty in all the medical colleges and different institutions. So a platform like ours can certainly improve the access and of course reduce the cost that we are talking about in terms of CME and all. And on the third front, it can also give them the flexibility where they can access these content at the time when they want to and at the place where they
Absolutely. I'm sorry I'll cut you there, but essentially, from all three of you, when I'm putting my views across too, sometimes virtual learning can take somebody to a virtual world. Training is good, but there are places where we need to guard them against carrying it too far. There is still a place which is mandatory for a mentor mentee relationship. And we need people to be trained practically. While these are doing a great job, the CMEs can help expand our classrooms as I started in the beginning. But there is nothing that can replace learning at the elbow of your trainer, because your mentor is going to teach you as to how to actually do it. There is a problem that people watch one procedure in a conference or on a YouTube, and then they want to perform the same procedure, it's not the same when they do it. So therefore, while there is an advantage with that e-learning and far learning, as you mentioned very correctly, but there's a flip side to it. Your views of that, Dr. Gupta?
Yes, I think I entirely agree with you that the virtual learning or e-learning has got a role to play only to increasing the efficiency and the skill part of that. But the basic skill has to be translated from mentor to the mentee. I mean, I can share one of the example at one meeting. The one college was given 36 seats for MD in one particular subject. For example, anesthesia. And we were discussing 36 PG students in 1 year. It means in 3 years there will be more than 100. How a resident of anesthesia department will get a chance to intubate, to be able to conduct. I mean, even given the time, there will be 4 or 5 residents holding the bag
Interestingly,
at one
Dr.
time.
Gupta, we got 65 this year. It used to be 21 a year. We got 65 per year for anesthesia.
But
So that would multiplied by 3 would be a huge number.
But I mean, on one side we have shortage, but at the same time, the training institutes do not have enough option for them to have hands-on training. I mean, to able to
I
intubate
agree
and
with your point
conduct.
taken.
This
You're
is a
right.
very, very
So
serious
it's very,
issue.
very important. Anything there, Dr. Oni?
Well, I feel that technology is just a tool, and it is in the application of the tool that the results lie. So, for example, if you look at institutes where electronic health records are instituted, or you have these technology-based institutes, you will find that sometimes in the desire to document things better, the patient looking at the patient's face may be a problem because the doctor looking at the computer screen. So at the same time, we can't argue that the process of documentation and digitalization has actually helped the patient. So it is in the a fine balance, the middle path where you use technology for the good, and at the same time you are able to ward off the problems with technology. So having a face-to-face learning, no doubt important, but there are areas where digital learning can also help. So I think it is in the discerning mind that can decide where to place this and where to place that, and that is where I think experts like you would come in and then be able to guide the country to better levels.
Oh, well, thank you. That's exactly the point that Dr. Gupta was also making. And you very rightly hit the nail on the head. I mean, a fool with a tool is still a fool. So, unless you train somebody to doing I didn't mean it in the literal sense, but you know that one can go haywire. When you have a hammer, you're looking for a nail all the time.
Yes, absolutely.
And everything looks like a nail. So it happened to, I mean, tool-based specialities grew up and people made it into a full-fledged specialty, while tool is to be used the effective way and training has to happen in that way. But there is a case for CMEs and distant learning, which have really contributed. And I must compliment Docplexus for doing it all. All these CMEs and webinars, they're being watched by lots of people, and it does excite a younger person to approach some of these people to be guided practically. But we wanted to highlight this point for a very specific reason. They shouldn't take home a message which is like that's the end of it. They need to go back and train and really train under somebody who can train them well. Well, we'll quickly move on. I mean, I think that's a brilliant take home. All of us agree on the point that we need CMEs, we need to expand classrooms, but there is no replacement for mentor-mentee relationship. And training is what we need to work at. I mean, if you train somebody well, actually you're sending into society a good message, and medicine as a profession would be popular if there are good doctors in the society.
Yes.
That is the point that Dr. Gupta also made. Now, just to get into the gray zone of the world, we'll never have an answer, but we'll try. Wings of medical infrastructure in India. I mean, when we talk about the country that is India, it's a land of paradoxes. You have at one end institutes or hospitals or centers which can outdo the best in the world. And like mentioned initially by Dr. Gupta, we are still struggling to provide basic health care. We still have an issue with dengue, malaria, communicable diseases. So it's a land of paradoxes. Therefore, there cannot be one answer to it. But what do you think has been the overall political foresight and implementation in terms of government expenditure to health, Dr. Gupta?
Yes, I think this is a very, very vital question from a social point of view. I mean, the health is an expenditure which people are really looking as an expenditure, not an investment. But I think it's a big investment. Unless we provide a good health atmosphere for our patients, good infrastructure in the hospital. I can share a few examples. During the some of the inspection report and giving the PG, I was very unhappy that some of the medical colleges in the state of Maharashtra did not have a basic thing like a blood bank. And that's a mandate thing. Without blood bank, we cannot start a PG program. And despite me approaching the competent authority at that time, it did not happen till now.
Well, so there is a problem
there is a
actually, and does it have anything to do with the political will, or?
I think it's very important because unless the Ministry of Health or the politician feel that no, why can't we achieve the excellence? I mean, that is a minimum standard requirement, but nobody stopped them going beyond that minimum standard requirement. If the health to a common villager also is as important as the VVIP in the city, then they should provide the basic infrastructure. And I think there lies the
That's true.
problem.
I
There
agree
lies the
with you.
problem.
That
There
is a
lies the
good
problem.
point. And political will also is a reflection of how the doctors have given back their idea to the politician, because politician is not supposed to know about healthcare as much as we should.
Yes.
So have we done enough to really encourage them into looking at it differently?
I think it's important at this point to talk about advocacy.
Yeah.
To what extent have we as a medical profession managed to convince the public health policy makers about importance of, say, a particular surgical or medical discipline? So that's where the role of a doctor, not just as a doctor seeing patients or doing research and education, but a doctor as a voice for the community of the patients he represents. He or
Well,
she
very well
represents.
said. Actually,
So
I mean, we haven't done enough
yes,
to, including all associations, and associations also sometimes end up being just those political bodies where people are fighting to be presidents and vice presidents and chairmen and whatever. But have we done enough to communicate to the authorities and politicians that this is what is needed? I'll give you an example of screening program. And one politician was asking, can we buy all the mammography machines? This was a breast-related issue, so I was involved. I mean, they were very happy to buy as many mammography machines as possible. So I have to say that it's not the machine that will do the job. You need somebody to read those,
yes.
and you don't have the infrastructure to do it.
Yes.
That's one. Number two, I also have to apprise him that screening is no longer the standard of assessment.
Yes,
In the
yes.
US and UK,
Yeah.
they are saying that screening is not the best way forward.
Yes.
So we need to do more about awareness. He said, what is that? I said, awareness means the person should know that she has to go somewhere for this. So what screening did to the world was that awareness increased and they started coming early. And screening for breast cancer cannot happen until we get a breast lump size of less than 2 centimeters. Our average size is 3.5 centimeters, 2.5 centimeters. So we are still getting advanced cases. So awareness is more important. This point was raised by Dr. Gupta also, and so are you saying. I don't, Mr. Fanish, would you have a view on that?
As you pointed out earlier in our talk, that there are two kinds of problem we are facing in healthcare. At one hand, we have good infrastructure, and on other hand, we are facing public health issues. So as a country, we are spending about 4.7% of our GDP on healthcare, which is very poor from the statistics perspective. So of course, we need to be spending more on what we are doing on healthcare. Like ICMR, we are spending like in annual budget only $230 million.
You don't expect research to happen.
So research to happen, at least one molecule takes at least $2.5 billion to come into the market. So with that kind of investment from the government, what do you expect? So at one hand, we need to increase the budget that we are allocating, and on other hand, we should also look at the limitations we have as a country. So some of the frugal innovations like we have in healthcare systems of Cuba, maybe we can learn something from there, or maybe we can learn something from what has been recently implemented in Delhi in Mohalla clinics. So maybe some elements needs to be improved on those innovations, but certainly working on both sides of the problem will
It's
accelerate
not, but you'll agree that there's no one answer to the problem.
answer.
But I think you brought in a very important point that in spite of whether we have informed the politicians or not, the expenditure on health has to go up. If you're really looking at R&D and then outcome, and then you want the best scientists to come out, you want Nobel Prize for genetics in this country, you need to be doing more. And basic science is not our forte. We are just lagging behind. And all those who are keen on basic science research, they have to go. And the funds are necessary. But I think that was a very, very important point. And you brought it in beautifully. Now, sorry, please.
One point I would like to add, because you mentioned about the association, the role of professional bodies. some way or other I feel we have lagged behind in our responsibilities. Most of the associations nowadays or today are more focused on the annual conference funfair and dinners and getting some election, etc. They are not really communicating their uh, contribution to the society or through their specialty to the ministry, where ministry can probably implement their suggestions. I think this is a very important responsibility of
You're absolutely
social
right, but there is a
responsibility.
little problem there. I'll come to there. You're very correct. Unlike in the US and in UK, the Royal Colleges are advisory to Ministry of Health for what should be done. American board is responsible. American College of Surgeons gives their curriculum, their advice. Here, even if I can give an example of Association of Surgeons of India, even if there are some right-minded people, people who are trying hard, even the present president is doing quite well, and he's trying his best to bring in ethics and other things. But the government is not interested. Actually, they don't listen to these bodies. That again is an issue. So you're right. Actually, they should do their job to bring in information, but they should be receptive to this, and then probably the expenditure on GDP, etc., can go up. So political will could be there, but there is a communication gap there. This is what we can work at. Now, there is something which Dr. Gupta was especially involved in, and I would like the viewers to know about the unique ID thing that started in MCI. And we'll have a quick word on it. So is it a roadmap to lessen the regulatory burden? Because there's no point having a policing
Yes.
on doctors. They're educated people who are supposed to be responsible, provided they are, because that is also important. With authority comes responsibility. We just don't want to be, we are noble people. We have nothing wrong with us. Don't look at us. Don't say anything to you. That is not, that is not
Actually, it
acceptable.
started this. I will share some of my
Please
experience
do.
and
Yes, please.
my thought. Actually, it started with one of the newspaper report which says that there are seven lakh doctors practicing in India, but most of them do not have a record. Some of the people who are already dead or who have migrated to overseas do not have still the MCI or IMR is maintaining their record. And that time, the Honorable Health Minister said, why can't we have a unified system of registration? And I shared my personal. I'm registered with state of Maharashtra with my Maharashtra Medical Council. I was given a particular number, and when you log into the Medical Council of India register, the same number, there are 4 registration on the same number with different state.
Oh, that's a problem.
So I mean, the UP also giving the same number, other Uttarakhand also giving. So then we came with the idea, ki why not we have a unique ID system? The first 3 digits should reflect the year of registration. Subsequent digits should reflect the state where it is registered. Then the X number of numbers, and also we thought we should add some extra digit to designate whether it is a postgraduate diploma or a postgraduate degree or a super specialty. So this was the idea, so that one unique ID, once you got a ID, with that ID we can know which year you have graduated, which state you are registered, whether you are a general practitioner, you are a specialist or a
You're right. So
specialist.
that made a difference. I think that is a step forward.
Yes.
Yes,
Take it
absolutely.
forward. That
Yes.
would really help. And thank you for that, Dr. Gupta, and for that contribution, because at least there's something is going on, and they're
Yes.
working on it now.
Yes.
And a lot of them cannot. And there's another issue with ghost faculty in medical
Yes.
colleges,
Yes.
which is a shame, really.
Yes.
Absolutely.
Yeah.
But
And
this
why
will
should
help.
one do it?
But this
Yeah.
will help. Once
Now, this
unless
would
you
help
have-
because you
Yes.
can't get. That's what I'm
Yes.
coming to.
Yeah.
So to identify and to have a tag, you don't then need policing, which is
Yes.
really not good.
Yes. Yes.
Now, a word about, that I'm coming to a very, controversial issue of doctors getting assaulted, which is actually a very big blot on the society. A society where doctors and all the noble people get assaulted for whatever reason. Assault is not justified. We are not trying to say, since we all share the same background, that doctors don't do anything wrong, but to be able to get the best out of doctors, the least you can do is respect them for what they do. And it takes a lot of hard work to become one. And they're working even harder to sustain what they are doing. And one doesn't understand that a doctor cannot smile if he has to see 100 patients in a day. It's different in the UK and US. You can't see more than 15 patients in a day. It's punishable because it is not expected that you'll do your best. And here the OPD could be full of patients, 200 plus, 150 plus. So naturally his behavior could be, he's not working in the same kind of an environment. Having said that, we are not justifying that there should be no communication. There is a problem with communication amongst doctors for which they never get trained. Thankfully, now MCI is introduced it as a part of curriculum, and there are communication skill courses that at least we run at our place, and I run it as a program for the rest of the country in our MedSicon conference. But this is an issue and problem. I'll take the opinion of the members of the panelists as to how they look at it, because generally we know the problem, and we don't try to say that one is right or wrong. But any civilized country, a society which is civil, would not assault anybody, leave alone a doctor, because there can come a moment when we were talking to a kid in the morning and they wouldn't like to be doctors, so you wouldn't have any doctors. So what do you do then? Who do you beat? You can't beat up the ghosts. So we have these, and they come out of the same society, so don't expect them to be angels when the society is undergoing changes. Dr. Gupta, your views on that?
I think this is a very important aspect, and I believe that we say society gets what society deserves. And eventually, if the society is going to beat up the hardworking doctors, no doctor does anything wrong intentionally. It may be out of circumstances, out of situation. And you also rightly pointed out, we also say that there has to be a foundation course for communication skill and ethics being taught to medical students from the time they join the medical college. And doctors during internship and during residency program, they should be taught to communicate with the patient about the good news and bad news also.
Yes.
There we are lacking in our training somewhere. At the same time, society also should follow certain restraint in expression of their anger out of something. I mean, incidents can happen, but just to react differently. And as I read somewhere in the management book, that you can't prevent the incidents to happen, but you can alter your response to that incident.
Correct.
And I think that's very important thing, both for the society and both for the doctors. The response to particular
Absolutely,
incident.
both need to be working at it, Dr. Uni.
Yes, I think it's a complex issue. I think, as mentioned, a change in society. And I remember during my MBBS days and during my MD in the Christian Medical College, Vellore, of course, the patients were much more trusting and friendly, and doctors were.
CMC they still are trusting.
Yes.
Fortunately.
The patients are. But at the same time, the society has changed from what it was before.
Yes.
Because people would like to know the internet is there, and a lot of stress in general life as well. So when there is a health issue that causes some sort of friction, the patients are agitated. So as both of you said, I think the solution is to train our medical students in communication and in soft skills. I think this is a vital part of
I
training.
agree with you. And actually, I'll just share with you one classical example. I was examining at an institute in one of the regional parts, some regional institute. The candidates were struggling to communicate even while presenting their examination. They're presenting their history and examination. They would start off in English. I'm not trying to say English
Yes.
should be followed, but that's the way we are. We have a curriculum that is British. So you can't teach in local vernacular. Now, they were not able to communicate. They were not able to communicate the history as well as they should. And I was looking, every year I used to go, so I was looking at what to do. So they asked me, can you take a lecture on skills of this thing, communication? And this incidentally happened one day after the exam. So I spoke to the local faculty. Most of the communication between faculty and the students is in their local language. This is where we spoil
Yes.
it. So again, the faculty is responsible. In our rounds, I made it mandatory that we speak only in English. Bad, good, whatever, everybody improves. But they'll have to learn that skill. What that does is they don't speak loose words in front of the patients, which the patients understand. Like in Hindi, they would say, iska, something which the patient can make up.
Yes.
So communication skills are a responsibility of the teacher. And a lot of us, while communicating with our patients, don't realize, maybe we realize, I'm not trying to say, that the student is watching us as to how we are doing it. And they learn a lot of it by sitting next to you or you, Dr. Gupta, or to us, as to how you behave, they start behaving with their patients. And that's where probably communication, although it can be taught, like I examined for MRCS, communication break is a very important break. Most students, most Asians have a trouble there because they are not used to it. So they cram it up and they crack it. It is getting better, but we need to work at the communication of faculty also. The way you communicate to the patient is what they would do. So overall, I agree with you. The idea is that we can put it in the curriculum, but end of the day, it has to be practically seen happening.
Yes.
So that becomes a day-to-day working. So at least they should be polite enough to talk to a patient. Doesn't matter how big is the struggle of number of cases. When breaking a news about death or cancer, or talking to the patient can be
Yes.
an issue, attendant especially. And importantly, as you very rightly said, it's the reaction.
Yes.
Even if it has happened, don't react in a manner
Yes.
that will invite an assault. I'm not trying to at all accept that society can do it, but if society is doing it, we just can't be reacting and making it all a hash of it.
I want to share one.
So we quickly move.
Sorry,
Yes, quickly one. Yeah.
I mean, it happened during the 92 bomb blast, serial bomb blast in Bombay, and I had several patients which I was operating practically from Friday night onward till about Tuesday morning. And incidentally, it was out of my practice or out of my this thing. Every time I finished surgery, I would call the patient relation and introduce the surgical team. This is the
It's a
doctor
brilliant
who has-
idea. So
who has
now what has
helped in
happened is Dr.
anesthesia.
Gupta's resident has
Yes.
already been trained into a communication skill,
Absolutely.
which can be in any language, but they can learn to be polite. That's the least you can do. It's the right thing to do.
And it happened that after some time, it happened that one of the anesthetists got met with accident somewhere, and there was nobody to help. Incidentally, one of the patient relation recognized this was a doctor who gave anesthesia to my
There you are.
and that helped. So sometimes these communication with the society on a positive side also helps building a faith in the society.
There's an apostle, no? For what avails a man so who gains the world and yet loses his soul.
Yes.
If you get down to the bottom of it, it is time that India rediscovers itself as a land of spirituality. If you're spiritually healthy, you'll be polite to everybody.
Yes.
We are going towards materialism in a hurry.
Absolutely.
And we're losing that essential component of living in this country, where you can feel, you can be empathetic. Indian by nature is empathetic. It's just that he's getting into a wrong tangle. By and large, Indians make very compassionate doctors wherever they are. Finally, we'll come to the last segment so that we can cover up for some questions. And that's about public to private sector getting together, where the training can happen. What the advantages of being in the public sector, where there are lots of patients, volume is good, the training can be very good, and lots of hands-on experience, lots of practical experience can happen. Yet at the same time, as I mentioned in the beginning, volume can be a strength as well as your weakness. So the weakness can be compensated by sending the same trainee to an institution which is sophisticated, clean, where where there's time for the faculty to train you into doing the right kind of things in a good environment. So if he's exposed to both, probably he can then take a middle path of Buddha and be fine. Dr. Gupta, quickly a word on that.
I think it's very, very important aspect of training in medical science is the rotation of the fellows and residents. The fellows can pick and choose the specialty they want to. They can pick and choose the institution they want to learn and the specialist. When I can share some of the examples, I being a plastic surgeon, both at the Grand Medical College and the Bombay Institute of Medical Sciences, and I get many people by rotation.
Yes.
And their exposure at the medical school and their exposure at the Bombay hospital makes a lot of difference in their approach. And this is something where we are lacking in India as a general.
Absolutely. I didn't ask you about the assault part deliberately. You can throw light on it now. What's your view? Because you'll have a view from the other side.
Because all of us were talking about the element of the society and what they think about doctor-patient relationship. In my views, the way the new generation, India being a young country, they are being brought up, most of the things that we buy or order as a service, it comes as a pizza. Either it gets delivered in 30 minutes or you get it for free. So there is a sense of entitlement to health and life. So when something goes wrong, for them, it's a very difficult situation and they react.
That's the mindset they were
Yes.
talking about, but that's not good news.
That's not
The
good.
burger cola culture and pizza attitude is dangerous. And that's where we got to train public into understanding through these kind of programs, hopefully, that don't expect it like a pizza delivery. It's a whole lot of human soul and body involved in. Now, about the public-private partnership, you agree on the same points? If it's more or less the same, we can move on. Yeah, what do you suggest on that? Rotation. We think of the trainees should be rotated in private and public hospitals to get exposure of both.
I think it's important because India is a vast country and people come from all strata of society. So it's important that our medical trainees have an exposure of how to deal with all sorts.
Absolutely,
So that's
absolutely,
very
absolutely,
important. So
absolutely.
that variety and that exposure to different patients, that will improve communication as well.
Absolutely. That's exactly what I was
Yes.
trying to say. They will automatically learn to communicate with all types. Otherwise, they get used to only one type. One is
Yes.
too polite for comfort, the other is
Yes.
too impolite for comfort.
Yes.
Both would be a problem.
Just a word of caution in this. We should not take these fellows. I mean, some of the private institutions should not consider these fellows by rotation as a cheap labor.
Oh,
They
that's
should-
what you
Yes.
ensure,
Yeah,
because that
absolutely.
is
We
the
have to
least
make
they can
sure,
do,
yeah.
because that will be
There has to be
wrong.
compulsory for them.
Telemedicine and the electronic health records, you highlighted it. I think I'll quickly sum up, because telepresence, telesurgery, telemedicine, they're very fancy terms. They came up in Europe because of islands being far and wide, and it was not possible to reach everywhere. You have helicopter doctors in Australia. These are services that are alien to India, especially where people would like to see a human being be there. But telemedicine has a role to play, especially in difficult circumstances where the services are being asked for. But importantly, in the healthcare sector, for reports, mammographic X-ray reporting, pathological reporting, one can rely on telemedicine. And many institutions, including CMC Vellore, our institution in Delhi, other institutions, say SGPGH at Lucknow, they are all connected by telemedicine network. Many people take opinion on mammography. There are virtual tumor boards. I happen to be part of that World Federation tumor board. So they circulate it, and it works out quite well. Any views on that? Any experience with
I
telemedicine?
think telemedicine is a matter of future which is going to happen. I can share that the government of India had set up a national knowledge network, now which has been converted to
Yes.
National Medical College
Yes,
Network,
yes.
and it has practically all medical colleges in the country. At present, there are 35 medical colleges, but in years to come, it will be
I'm glad you
75 to
made that
100.
point. Yes.
These are all going to be connected to the National Library with a high bandwidth scheme.
Very
And
right.
all the libraries will be digital, like I'm at the Academic Council of Maharashtra Health University, and all the medical colleges in Maharashtra has got more than 30,000 e-journals to this bandwidth available to
So
them.
it can make learning
lot of
easy.
learning.
Yes, pooling of
This
resources.
is something future.
And
But
you said on electronic health records. Anything
Yes.
on telemedicine? Your experience here?
Well, I think the role of e-learning is increasing. Of course, we ourselves at the Chalaram Diabetes Institute, we had an online diabetic foot education course, I think in collaboration with the Docplexus team. We found that there was a huge interest to know and to learn, and I think almost in very
At least it
short
can
time-
prime them into
Yes.
learning in that direction.
Absolutely.
No? Yeah. And we have, before we go to the question answer, which is also very, very important, you have an issue with the last part, which I think I'll take before the second last part. Pharma industry and, association with pharma industry and doctors, why is it considered a taboo? You were in the medical council also. So how do you look at it?
I think during our tenure and in thereafter also, the medical council is clearly defined in consultation with the Association of Pharmacists that a particular gift beyond that particular range is not something which is acceptable. I mean, pharma companies and some of the doctors or professionals have really gone beyond the acceptable limit
Exactly.
of getting.
Although they are
sponsorship.
needed,
Yes.
but they've gone too far.
Yes.
And it is a problem when they buy an organization, and pharma industries are active in US, UK, India, everywhere. But going bizarre and not being there for the right reasons, unethical practices can be a serious problem. It's a shame that you can exploit it to that level. But they have a role to play, and for all the basic research that happens, for the R&D that you need them, because they are needed. One cannot say that relationship should not be there, but it should be ethical and well regulated.
Yes.
Views on that, Dr. Uni?
I completely agree that there is a role for advancement of science and availability of medicines. And I think good ethical practices and regulation, that's the key.
Mr. Phanisha, on that.
Yeah, as we were talking already in the morning today, that pharma plays a role in bringing new molecules, and it requires a lot of investment from their side. It is kind of very imperative that they will be spending a lot on their marketing efforts, making it ethical and also effective. If we look at some of other markets like US and all, they have introduced Sunshine Act, and India, they're talking about UCPMP and all. So all these acts, if implemented in a right way, can put in right checks and balances where we have
So there is a
education
role, and it
yes.
can be regulated, and it can be ethical and
Yes.
acceptable.
Yes.
We cannot just make it into, we can't write it off. At the same time, it shouldn't become, a source or the reason for malpractice, because it's not mandatory that if you're using a product, you will use it because somebody took you
Sure.
for a ride. If
Yes.
you're doing it, it's the wrong thing to do. At the same time, associations doing conferences which are funded, I mean, exorbitantly, where you may not need that money, also should be discouraged. It should be an ethical conference. It should be conferences that are about academics. So we should not be selling ourselves into it, if I can use that word crudely. There should be a symbiosis, mutualism, where they provide because you can't have conferences also happening. Most of the time you would be confused. But otherwise, conferences are academic. In the West, if you go, there's nothing like gala dinners and
Gala dinner.
lunches. There are no free lunches. You buy your lunch and you come for the academics, pay registration fee and attend it. There's no reason for a huge banquet where, or I use the word that, going on a cruise and then doing a meeting. These kind of things can be a really glaring examples of malpractice, and therefore we should try to have a middle path. A check and balance is then necessary, which shouldn't be like the MCI putting a stick all the time, but MCI can be a guideline. They expect the doctors to behave that way, so we don't need a police. They are doing what they're supposed to do. They are a regulatory body. They are stopping it because it is supposed to be stopped. But we can do it ourselves. Now, we have had a wonderful panel discussion. Most of the questions were addressed and answered very well. Some would still remain, and there are some questions here. Before we run out of time, I'll have quick questions, and there are quite a few actually, and I'm sure more are coming. So this is Dr. Anil Kumar Sood. It is written Stood, but I'm sure it must be Sood.
Yes.
Is it worth spending 10 to 12 years of your life in studying and then landing in this country, worshipping the politicians and dirty bureaucrats? Well, I would finish that question very straightforward. There's nothing worth it. Life is not worth it. Everything is wrong. It's a cruel world. Why are we here? But remember, the world is only as good as the people there. So it is not all dirty. It's not everything wrong. And we are not talking out of our hat. We are not talking everything is good about the world. The world has been the same. It was here before we came. So let's not talk about the world is wrong. Let's 10 to 12 years of your life is spent studying because you want to study medicine. I think that again is another stigma which I'm looking at.
Yes.
You can't be blaming the world for those 12
Yes,
years.
yes.
You chose it and you're studying it. So I think that is just one way of looking at it. I'll just
It
not
is
take
their
it
choice
forward.
to worship
It's your
politicians.
choice. If you worship politicians, it's your problem. We don't worship
We
anybody.
don't have it.
You can worship Almighty and be happy. I can have only one suggestion. I mean, using the word dirty bureaucrats, I don't like that statement because I've known wonderful bureaucrats who have contributed immensely, and politicians have contributed to our present state. We have done very well in the last 70 years. There are countries around you that have gone to dogs. We are a wonderful, thriving democracy. Let's look at the positive side. I'm
Yeah.
sure you're angry. So don't be angry and think at the same time.
Our institutions are far better than some of the neighboring
Absolutely.
countries.
Dr. Ajay Joynath Shinoy, to your point, sir, why is there an age bar for training in this country? I like this question. Dr. Uni, your view on that. I'll start with you this time.
Yes, well, I think that at any age,
Quickly, you
knowledge-
agree with this age bar or you don't?
the age bar for working.
Any training?
No, I think anybody who
For
would
the
like
age
to
bar
train-
for training, and let's stay working also.
I think as long as you're medically fit, people should be able to work. That's
Dr. Gupta.
No, I think there is a sense in that.
I
because this
deliberately
is-
started from the younger
Yeah,
one.
because this is what we felt also, that the minimum age for admission is 17. Prior to that age, average capability of molding or understanding is not so good.
But I think he's talking about the
No,
upper
even
age.
after that also.
Yes.
By the time they finish their training, and if there's a gap, this was a question which was asked to us. Somebody has failed 8 times in MBBS or 9 times, and after that he wanted to pursue his PG, and there was a gap of almost 7-8 years after he finishes MBBS. So for person who wants
You think
to
it
go
is,
for-
we have to take
it
many
should be a
questions,
gap between the. I mean, we should put
so-
a
Agreed.
limit.
So you have a view that they can be, but I agree with Uni in the sense that if you're good enough, you should be good enough.
I think
You
it should be
able
the
to-
merit that matters.
Yeah, we are suffering because of, why restrict somebody who's 50 and capable and can teach people? We're wasting talent there. We just put those age bars. Why? How does it matter?
No, but-
We're not taking somebody beyond 32, 33. Why? We are restricting the entry of good people. If you don't want to select somebody, there will be other reasons also. I think a 30-year-old incompetent fellow is inferior to a 40-year-old competent person.
Competent, yes.
There,
Or a 60-year-old
while I
competent.
agree with the minimum age, you can't really have somebody
Yes.
less than the age
Yes.
to come in.
And we are
So we
also-
agree with you, sir, Dr. Shenoy. Your question is wonderful. I must congratulate you for that question. And we don't have an issue with that. It is, I think, bureaucratic to have that cut off. They try to put up a central government job because they look at it as another government job. I'm in a central government institution. They look at it as another job. It is not another job. Somebody could achieve competence at 60. In UK and US, you can continue to perform till you're fit. You got to give that fitness test. The other problem we have is you get into the job, no fitness test after that. You may be unfit and you may continue. So I think to have a fit person at whatever age is acceptable. Dr. Chandra Mohan Godala, how to practice without litigation in India in the present era of high expectations of patients with a meager amount they pay. In spite of best efforts, we may have to face the agitations. What to do in the present scenario? By and large, we've answered it, but if you could briefly say something.
Yeah, I think there are certain built-in ethics and practices, good practices and fair practices. If you follow them and stick to the goodwill part of the medicine, rather than making the money as a primary.
So you
focus.
basically concentrate on the ethics, communication, and well, you don't live in the future. Everybody lives in the present. The past is already dead. Future is yet to be. We can talk about present. If you can do your present all right, future is going to be okay. But to sit down and keep worrying about when will the litigation happen, it'll happen tomorrow. So try to stay away from it. Do, as he said, ethical practice, be communicative. I think most of the litigations have been observed to be due to, we've had many discussions on this, communication related issues. You promise moon and then you don't deliver. And don't let's blame just the patient for it. Dr. Uni, your views
I
on
think
that?
average clinical judgment. I think as long as you don't make huge commissions of blunder or huge omissions, it's fine. An average good common sense clinical judgment should see us through with good communication.
Absolutely, very well said. Common sense, which is extremely uncommon, is what we need to work at. And if that happens, by and large, we'll be okay. You have a view on that? The other side, you're safe. Then we have a question. We'll try to take quickly all of them. Dr. Fatima Anthony, how can we sustain our practice, especially individual clinics, with competition from growing corporate hospitals, Google Doctors, media health awareness programs, etc.? Now, how can we sustain? This is a good question, Dr. Anthony. I must congratulate you for that.
Yeah, with the Clinical Establishment Act becoming a reality, gradually it is going to be a corporate hospital, large corporate.
Is that good news or bad news, sir?
Is a partly good news, because then the basic infrastructure which can be provided to patients is.
I think you made a point. Actually, if you really look at it yourself, now I'm looking at you. It would be fair to the patient, if you were a patient, to be in a place where it's one roof clinic. Everything should happen at least one. You shouldn't be sent around. I'm not a very big fan of the corporate culture per se, but it is here to stay because everything is getting corporate. I mean, there's no way you can escape from it. I didn't use the right word for that, and I wanted to skip. Basically, it is about providing the complete care in one go. You would like it too, but I think if there is a nexus of the corporate culture, Google Doctors, it is a problem. It's a problem that we'll have all to deal together. You raised a question. I don't think we've answered it completely, but partly yes. The answer still lies within us. You'll still be relevant even as a small clinic if you can provide a family health service. Everybody cannot afford a corporate hospital. And very soon we are going to get back to square one in some way or the other. So we'll have to find a middle path yet again.
Also,
I completely agree. I think in every threat is an opportunity, and you mentioned Google Doctor. So use technology to improve visibility, to tell your patients, and as the patients now read Google and come to you. So we can also now, it's good because we can be completely transparent with the patient and share everything.
So better be an educated doctor,
Yes,
rather
absolutely.
than blaming the educated patient.
but I think the health insurance being provided by various agencies also is an issue in the individual clinics.
I think that is an issue,
Yes,
and I think we
you're
didn't. That part is, I mean, important. With the health, what is happening world over? You don't have small little clinics running it. A good referral system, good training, I mean, chain of evacuation, and insurance for health is what is the way forward. You don't have a choice, and there's no point looking back when the world is moving forward. You will unnecessarily be constantly living in the past. It was this way, it was that way. Future is going to be different because the present is changing very rapidly.
And may I just
Clinics
add
can
that,
be, sorry,
sorry, I thought I'm sorry, may I just
no, it
add
could be
that,
affiliated to corporate hospitals also. I'm sure they're going to build that, bridge that
Yes.
gap, and you will have an answer. As like I said, the middle path. You will also be relevant. Everybody is relevant. You would be part of that corporate culture very soon. You can't be left alone.
Yes. Yes.
Yes,
no, I was
Dr.
just saying that, the government also is likely to be responsive when a change towards a corporate culture occurs, then the government will also allow a shift back towards family medicine, which has happened in some countries. So you can
Correct.
expect, that
Correct.
sort of.
Correct. Now we have a beautiful, lovely question now from Dr. Deshpande, and that is Dr. Harshad Deshpande. According to you, how is NMC bill going to impact medical fraternity? I don't know. I'll ask them.
It's $1 million question to us also, because Medical Council was established in 1933. Almost for 70 years, it did a good job of regulating the medical education. Because of certain issues which have changed with the time, just to completely disown that Medical Council is bad and they are not doing job, and the new bill will make a solution for all this, is difficult question. Only
Hopefully,
thing,
I mean, if I can just second it, hopefully it's going to be something better because you can't go back. And this is expected to deliver better. Let's look at it because nobody can predict how will it perform. And MCI did not do too badly also for a long time. But then
Yeah.
we actually, why do we always forget that we moved forward? We are not
Yes.
completely backwards. There are a few things which have improved, and in a democracy like we are, which is we are proud of it, there are too many people to be taken along. The movement cannot be fast, otherwise it will be China,
Yeah.
where everybody moves with a stick. We have to move with various opinions, like
Yeah.
people have different
Yes.
opinions. But the good news is, whenever we reach, wherever we reach, it'll be the right place to go. And slowly but correctly. There's no point running in the wrong direction, galloping away to glory. I mean, moving slowly but in the right direction is the right approach. We could have done better. I agree with you. And NMC is supposed to be, hopefully, going to be
Yes.
doing better.
In fact, we discussed also that currently the MCI is doing job of three bodies: ethics, education, and standard, which in Australia is being done by three different bodies. So maybe it is the time to split the responsibility and share the responsibility.
Dr. Oni, there is a question which is very straight and direct. NMC, you have anything to add?
No, I'm fine.
Now, why are PG, this is from Dr. Ajay Jainath Shinoy. Why are PG diploma holders being relegated to non-entities in medical colleges when it comes from being a teaching faculty? I mean, diploma means like DGO, DORth, DLO, and any diploma. Why do you think? I mean, why should he know? How would he know? I mean, why they've been delegated? But I'll still pass on.
Well, I think diploma holders are allowed to practice like a specialist in every way. But I think there could be a channel that is brought in to allow them to have a year more of teaching experience and then become faculty members. Or there could be some sort of a channel built in for
Actually,
them.
they are not. I mean, if I may address that straight away, they are not trained into the teaching part because diploma doesn't have the thesis,
Yes.
and they don't have the assignment as a postgraduate student of teaching the undergraduates. So it's not a teaching period. That's what they're looking at. And Dr. Unni was mentioning maybe they would be given 1 more year or 2 years, like they've done for diploma
Yes,
DNB,
DNB.
where they've been asked to do senior residency from a teaching institution for at least 1 year, so that they can be trained into teaching. It's a serious job. Teaching is the essence. If you want to improve a country, improve its teachers. That's what they say. And that's true of medical profession also. So the nation is made by teachers. And we are actually responsible for bringing up our next generation into doing well. We have too many questions to take. If there's a quick point to make there, you can make it, otherwise you can move on.
Yeah, we have
For
medical
diploma,
council,
PG
many
diploma.
centers are discontinuing their diploma because there are not many takers. And as rightly said, there is no thesis, there is nothing. So
We don't
have-
really
yeah.
think of it. Any views on that? Dr. Rajiv Singh has asked a question. How do, in your view, it would be possible to make qualified doctors of India practice ethically when medicine system of countries flocking with unqualified and semi-qualified so-called quacks and quack doctors should purchase, opposing challenge to very survival. Actually, it's a very long question, but basically he himself mentioned there are no ethics, just money. So improve on this. The need is good, greed is bad, lust is a disease. So if you really stick to your need also, it's okay. Greed is where the problem comes. But that's still okay. It's pathological, but partly we are de-differentiating. And finally, we get into the lust system, which is, you answered your question. When will the working atmosphere of medicine in India show any sign of improvement? When, if you're asking me 10 years from now, how can I say? How can anybody say?
I think
You will make it. Why don't you look at how will you change it in next 10 years? We all have questions to ask. I can ask many questions, but we have to find answers also. The answer lies in your question, and it's good to see that you're thinking about it. But hopefully it will change very soon. Money, just money and no ethics. That's true of the society as a whole. The policeman and the thief, they come from the same house these days. You can't really blame policeman or the thief. They come from the house. It's your upbringing, your training, and your desire to be good and acceptable. I mean, since we have too many questions to take, I'm sorry,
I think
unless Dr. Gupta has to
what
make
we
a
said
point.
in the beginning, the self-discipline is the best answer for this.
Self-discipline, ethical practice, looking at the patient not as a customer. I have seen in some clinics, I'm sorry, they put up Mahatma Gandhi's picture where he's talked about a customer is God, treat him like a God. He's talking about businessman. They've converted it into patient is a, they've replaced it. Every patient, the Mahatma Gandhi did not write about that. You treat a patient not as a customer. He's a human being who's sick. And the job of a doctor is different. Don't try to change it. If you change it, if you want to be treated as a doctor of the past and you behave like a doctor of today, it's quite likely that there will be a conflict. We want to be treated as the gods that people treated us as in the past, but we don't behave like the ones who did it in the past. So let's look at the whole thing in entirety. Let's not just blame the system. We are also responsible for the system because we make it. Thank you. Then we have two quick questions, maybe. Dr. Majumdar, comparing the population in India, number of doctors produced in proper academic system is very less. It has created crisis in country. Under-merit students are promoted. Under-merit students are promoted to doctors as against huge donation. In practice field, they could not keep up the patients for waiting from recovery of the money. Patients for recovery for money. They are under the trap of health business class. Doctors' reputation is the brand of the community. I'm glad you said it. Politicians and local parties are well aware of the crisis of doctors, but they victimize the doctors for unavailability of service. Please discuss.
Actually, in one of the report submitted by Dr. Srinath Reddy in a WHO, mentioned that India is the bottom. They are third from the bottom in the doctor-patient ratio. And that is the key issue. Unless the infrastructure at the various medical colleges, and we said the district hospital with 300 beds can be converted into medical college, and that will probably access another 20,000 seats per year. Unless we do that, and that requires a lot of political will and the infrastructural support. Otherwise, some of the private colleges are good. I would not say everybody is bad, but some of the private colleges lack the basic infrastructure, and they are still producing doctors just for the sake of money.
Manish, your views on this?
I think that, as you have pointed out, that addressing this doctor-patient ratio, which is about 1,700 to 1 in India, needs to be addressed. And one way to address it could be like another question that we had in discussion. Can we allow some of the doctors who are already available, maybe who are retired and all, and ready to contribute? Like we talked about having upper age of doctors who cannot serve, maybe we can utilize those. To address this issue in short term, because investing in medical institutions and colleges,
it's not cost effective. I agree with you.
It would take a long time to have a result.
It's not cost effective to keep building institutions, Dr. Oni.
No, I slightly disagree on this. To build a future, you cannot rely on somebody who's already exceeded.
While you're while you're building it, you can implement. So middle path would be you increase the numbers, but not just the numbers. That's also an issue. He pointed out another thing which probably we could miss, that they should be optimally equipped. It's not that you build up, convert a small little place into a medical college, which is happening, and you bring them out like sausages, and there are 150 produced. Okay, let's have 250 next year. Let's have 300, so numbers is filled, but they should be trained optimally. Because after all, your healthcare is a right of a citizen, and they should be provided a good health support.
I completely agree. I think there should be as many doctors as we can train. But in addition to that, I must say that there may be some, a doctor has to do so many things. A doctor has to sometimes explain diet, exercise advice, compliance with medicines. I think with good support staff like paramedics, and when you look at good paramedical support, like for example, nurses. In UK, for example, nurse educators play a large
Nurse
role.
practitioners.
Yes,
I'm
nurse
glad you brought
practitioners.
that point up. I wanted to talk about it. Nurse practitioners in UK. Actually, I've had the privilege of writing 3 books for nurses, and they were all courtesy of the college. MSN Lewis is one of the most read nursing books which I did, and it's a joy. When I did that book, I learned myself. And there's a Moroney's book on surgery for nurses, which they wanted me to redo because both these people are not there anymore. Incidentally, unlike my other books on surgery and oncosurgery, these books get the maximum royalty. What I learned there was on nursing practitioners 10 years ago, but their training is so good. And in UK, you would have seen wound clinics are the diabetic foot clinic is
Yes.
manned by nurses. The breast nurses do all the job of social counseling, taking care of the patient after discharge. But again, the question is training.
Training.
We haven't trained our nurses enough to be able to have nurse practitioners. Again, in the name of degree, there's a term called degree sans training, training sans degree. What would you prefer? I think training sans degree is all right. What is happening is you have too many MCHs produced every other day. Everybody wants to do some MCH. He has hardly got any training. He has not been able to handle the kind of training that people did in the past. So MCH of the past is not the MCH you have today. Same is applicable to MS or MD. So we are gradually just producing the degrees. That again is not an answer. I go by what Manish made a point actually. Let's not lose on a very trained, I mean, Dr. Gupta would be relevant for another 30, 40, 50 years, as long as he can offer himself to train, to mentor. We'll be happy to do as long as we are alive. Why? Because we would be passionate about teaching, sharing it with our people, students. We learn from them and they learn from us. A teacher is as good as the students and vice versa. So who would not like to teach? If you just retire them much before they are,
Absolutely.
they're actually not capable of delivering, it's not fair. We are wasting a lot of resources there. They practically now realized it and they're advancing the age of retirement for this reason. But at the same time, the acute problem can be solved. Chronically, you'll still need to train people.
Yes.
You'll have to build on institutions. You'll have to take them forward. Well, we have last question, which I'll take half a minute to complete because we can't take any more. I'm so sorry. We'll be replying to them online whenever we can. Maharashtra government are planning to give the post of medical officer to BAMS doctor in the government hospital. In your opinion, is it good? In your opinion, is it good? Good, bad? Will do.
Well,
I'm not in Maharashtra, so I can safely ask you.
Well, I think it needs to be thought through, and I think it needs to be in line with
Any good or bad?
well, we can't say because it's a decision which would have been thought through with a lot of effort, thinking behind it. So I think it needs more
Dr.
discussion.
Gupta, we need a crisp one.
Yeah, I would like to, because I was also part of the academic
So you
council.
must be there. That's the last word should be yours.
Who has raised this point?
Dr. Sayyid Arshad was the question.
Which course for these people, because they are going to practice allopathy. But point is, this has come as a need by the state government. There are several centers, sub-centers which do not have doctors. At the same time, there are very few allopathic doctors available. These doctors are available to go in villages.
Yes.
So why not employ them, put them on board? There's nothing harm, but as long as their training is also in common allopathic conditions and conditions is also being implemented to them.
Absolutely. I think he's hit the nail on the head. Now, basically, it is not about BAMS or MBBS. Something is better than nothing. If you don't have anybody there, a BAMS is better than nobody. And then an MBBS is better than a BAMS. An MD would be better than an MBBS. We can keep adding on. But one thing which I would like to reiterate, as Dr. Gupta mentioned, he's seasoned, he's seen it all, and there are reasons why he would know answers to all of these questions. The point is, if a BAMS practices allopathy, it would be wrong. He should be trained into doing it. So the bottom line is again training. There came a concept of barefoot doctors on the Chinese model. It failed because they were not trained optimally. You can't just play with the lives of people. Patients come with loaded 5% dextrose saline and the bowel is edematous by the time they're taken up for surgery. It does more harm than good. So, it's not no point having, I'm not using that word or phrase here, and half trained is worse than not trained at all. You can at least refer. But they can be trained optimally and we can use them. And the reason why these doctors have been taken is because the gentleman who has asked the question may not be willing to go there. Because if certainly they have an MBBS doctor, they would refuse an MBBS ahead of a BAMS. I'm sure that won't happen.
Yes.
When they don't get one, that's what they do. Ladies and gentlemen, I'm sure you enjoyed it as much as we enjoyed getting it to you. Especially for me, it was a learning experience. I thoroughly enjoyed the company of such eminent panelists who contributed immensely to our understanding of the problems today. We have just made a little dent in it. We couldn't have even touched it. I hope we have made a little dent. It's not that we could have answered all the questions, but we tried hard to give you the honest answers to some of the questions which are very difficult to address. We are also looking for answers, so don't think we have the answers. All the answers are not with us. It was a pleasure having you all on board, and I thank all the panelists for being such active part of this discussion. And we would conclude on a note that the management of patients, the healthcare, is although a state subject, but there has got to be a national policy to it. We should be looking at the future, not just the present and the chaos, but we have to improve on our present to make our future bright. And I'm sure our healthcare will go further forward. We are now thriving on medical tourism. The neighboring countries are coming here for treatment. So there must be something good about India that is attracting healthcare support groups coming to India in large numbers. On that, we sign off. Thank you all very much for being an active part of it. All you viewers for sending these questions. They made us think more, and I'm sure there'll be more questions. You're welcome to send them across. We'll try to answer all of them. Thank you very much.
Thank you very much. Thank you. Thank you. Wonderful. Wonderful. Thank you.
Thank you. Thank
Very
you.
nicely done, sir.
Thank you.